That's wonderful. Three great presentations, lots of information there. And I think what's important now is that we try and kind of boil it down into something that we can all think through and get our heads around for the panel discussion. And so I'm going to share a video again. And you can tell that we like videos here. We've created a little 2-minute video that we think brings it all together for you. And hopefully highlight some of the themes that we can talk about in the discussion in a second. All the videos that we've shared today are on YouTube. I've put the link in the chat there. Everything that we share after the webinar will also be on that YouTube channel. So make a note of that if you want to watch these again. So yeah, just 2 minutes and then we'll start our discussion.
Small steps, big changes. Meeting the mental health needs of children and young people. We identified 4 themes: getting help, continuity of care, choice and bespoke care, and organisational culture of learning. Getting help. Rapid access and short waiting times work well. Clear signposting online and in public places helps children, young people and families know where to go for help and how to access it. Self-referral and open access are welcomed by children, young people and families. Accident and emergency departments with a dedicated area for children and young people are effective and welcomed. Continuity of care. Support works well when it's clear how to move on to the next service, regardless of service age limits. The provision of 0 to 25 years services can help with continuity of care. Choice and bespoke care. One size does not fit all. We are all different. Children, young people and families like learning practical skills about how to look after their mental health. An ideal service offers a range of support so that children and young people can choose what works best for them, including creative approaches. Children, young people and families want staff in services who are approachable, caring, empathic and person-centred. It's really helpful for everyone to know in advance how information will be shared. Organisational culture of learning. Services feel welcoming, effective and helpful where a learning culture exists. A learning culture is demonstrated through good team relationships. A reflective learning environment incorporates learning from other team members as well as from those using services. Staff benefit from regular clinical supervision, reflexive learning, reflective practice and the freedom to innovate. Join the conversation on social media. #CAMSSmallSteps.
Okay, so we've got some obvious things in there, perhaps some slightly more contentious things. So very interested in what the panel thinks of all of that. And what you think. If you're watching, do put your comments please in the chat. So I'm going to introduce the panel now. Feel free to turn on your cameras, panelists. We've got a really great, diverse panel here today. We've got Bekah Carrington, who's a co-researcher and a data and research analyst at the Local Government Association. We've got Sahil Dodhia, who's a senior project manager for children and young people, an expert by experience at NHS England. We have Emily Edwards, who's a commissioner from Salford. Dr. Shermin Imran, a consultant psychiatrist from Manchester. Kaye, who's an advanced clinical practitioner, also from Manchester, and Professor Paul Tiffin, who's an honorary consultant psychiatrist and academic researcher, Professor of Health Services and Workforce Research at the University of York. So a very warm welcome to our panel. Thank you so much for joining us. We're going to have 4 questions on those 4 themes that we've identified. And so the first theme was getting help. So how can we get help in the first place as young people affected by mental health problems? Shermin, I'd like to put this to you first of all. Why don't all children's mental health services have this kind of open access self-referral route? What are the barriers to that kind of open access service?
André, thank you. I think it's a really good question, and I'm not sure I might know the answer from the perspective of all the various providers, but I can certainly share my own sense and observations. And I think probably in my mind, it does link to workforce issues and perceptions that services have of their capacity and how they might be overwhelmed if they were to sort of, kind of produce certain changes in the pathways, including something like self-referrals, really. So I think my personal observation is that it feels like it is something that services feel unable to or find it very difficult to introduce or sustain because of the sense of how that will be managed, whether they would really have the capacity to do it. Because inherently the pathway kind of works like that the professionals who might be talking to the young person or the family and then helping them to make the referral to CAMS also do the function of filtering a little bit or thinking about what other services are available that might be able to help them before a referral to a specialist CAMS service can be made. So that sort of filtering function, in my mind, might then be lost, really, is what the perception of providers might be if the referrals came directly to them. So obviously, there would have to be more of a capacity at the provider level to be able to look at all the referrals that are coming in and provide that filtering function, which will really need to be think about. That is just one of my observations, but I'm not sure that is the full story.
Thank you. That's a great way to set up the conversation, though, for us. Emily, from a commissioner's perspective, do you want to come in and give us your thoughts on this?
Yep, sure. There's lots of different influences on accessibility, really, and certainly from a commissioning perspective, budgets come into play and capacity of the system and of professionals and providers in responding to open access referrals. And there are ways in which this can be managed, I suppose, which lots of localities and providers are exploring collaboratively around things like joint triage services or SPOA, or a single point of access point. Certainly that's something that we are working on in Salford, which would be a collaboration between our early help, social care and mental health services, coordinating together a single entry, if you like, for requests for support, access to advice, consultation, or to make a referral. But I suppose the concern from the provider perspective and from a commissioning perspective is that if every individual service had an open access, there wouldn't be enough capacity necessarily within the professional system or processes to be able to manage the demand. There's a lot of issues around workforce capacity at the moment, recruitment, retention. But there is a huge amount of variation in that. So some providers are continuing to provide self-referral routes and actually think that the quality of referrals is better by having open access and self-referrals. And that filtering that was just mentioned, whilst it can be helpful from a sort of triage perspective, can also result in kind of unnecessary steps from a young people and families perspective if they're having, for example, to go to a GP in order to access a service and not necessarily get into the right place, because GPs can sort of send those referrals to the wrong services, not necessarily the best services for young people and families, or do a scattergun approach, and that's send a referral to every available service to see which one comes up first. So there's kind of unnecessary barriers in the way. Just one further thought around crisis care particularly, and work we're working on within the GM footprint is around the use of 111 and option 2. For providing almost a single point of access to the public in order to access advice directly from mental health practitioners and therefore get routed to the best service for them. So that's a development underway now that we're hoping to align to our children's crisis services in Greater Manchester from 2024, and we think and we hope will make a big difference in terms of self-referrals.
Thanks, Emily. I'm going to bring you in a second, Sahil, to kind of give us the NHS England perspective on this as well, from your kind of project management perspective. I'm really interested in the idea that by doing this, we're going to increase demand, because there's that sort of intuitive point, isn't there? If you open up the service, we're going to get more people piling in, but that isn't necessarily the case, is it? I think it's much more complex than that. There's ways in which we could do this and at the same time make it easier for services that are currently overwhelmed. Yeah, Claire, you've got your hand up.
Yeah, and just a point on that very note, Andre, in the comments, an attendee has noted that anecdotally and admittedly, we sometimes assume that self-referral is going to massively increase demand and it'll be, opening the Pandora's box. But from their small sample, they've found that's not necessarily the case.
Okay, interesting. So Sahil, I'll come to you first, and then Shermin, I see you got your hand up as well. I'll come to you in a second. Thank you.
No problem.
Thanks, Andre. This is probably just more from my lived experience hat, really, in terms of some of the issues. So I think some of the issues, and you see this kind of within services, but also I've seen this from my personal experiences, that kind of risk aversion and kind of the sensitivity when it comes to children and young people, specifically if you think about children and young people under the age of 16. I know there are very many nuances around how to support children and young people who are self-referring, and some of the issues when it comes to safeguarding, for example. So I think sometimes we can get quite caught up, and they're really important issues to think about. But I think, on the flip side, it is really, I mean, if a young person was able to kind of refer themselves and really say, I really, hey, I'm struggling, I need help, it's so powerful, and it's so meaningful. And I think for a young person, it's kind of empowering actually to say that, and we're teaching them the right way of doing things. We're teaching them actually, if you reach out for help, we're going to help you. And I think right now we're in a position where, unfortunately, we do kind of, we're in this cycle where young people have to kind of be at their riskiest to receive support. So they're receiving support top down. And, I'm seeing that becoming quite a problematic cycle. I think one of the things really to think about is what does happen in the interim when a young person was to refer themselves, due to capacity and workforce issues, and how do we support that young person so that they're not kept on a waiting list for 6 months. So I know I've seen some kind of third sector organisations operate a self-referral model, and young people who have used their service have designed resources for the interim. And so there's like a kind of 4 weekly check-in with the young people. They're sent resources on an ongoing basis, and they're signposted to kind of crisis support and telephone support. So that's one of the things that I've seen working quite well.
Thank you. Brilliant. So very briefly, if you can, Shermin. Yeah.
No problem. I think listening to Emily, just kind of, and now other comments as well, I wondered where we are good at, because I'm not sure we are, as providers, to share with each other our experiences. So particularly services who, despite similar challenges, have managed to work with the self-referrals and have had a particular experience that was helpful and have had challenges that they've overcome. How good are we really is a question I'm asking as providers in sharing this with each other to inform our practice. Probably not as good, but I really wondered whether Emily had any thoughts on that really in her work as Commissioner across GM.
Emily, do you want to come back in?
Yeah, happy to. So yeah, I agree. We're probably not as good as we should do, and probably don't make enough time to do that kind of sharing of good practice. But coincidentally, and I know you've got a representative on the webinar today from our GMI Thrive team. There are communities of practice through are kind of Thrive networks, which bring together a range of different experts, I suppose, the experts by experience, the commissioners, programme project managers and service providers, so frontline workers, which can kind of bring that learning and experience together. So the example I gave earlier of Salford trying to develop that single point of access, which was a response to pressures on GPs initially, but will actually hopefully become a solution for our parents and young people in Salford by having one place that they can go to ask for help, which will hopefully direct them to the right place, is an example of what we would be sharing at that community of practice tomorrow, and learning from each other about, you know, what works, what doesn't work, what the pitfalls are that we can avoid. So I agree. I think we need to do more of it, and we need to kind of protect that space for being able to share our experiences and to look at good practice and learning from elsewhere, and continue to be open to that.
Thank you. Okay, time to move on, talk about continuity of care now. And I'm going to come to you first, Sally, with this question. How do we help other organisations, so for example, adult mental health organisations, to better understand what children and young people need as they move out of youth services?
Thanks for that. Can I just briefly mention on the last point, just that we did do a self-referral in the crisis team. I know Joe's put that in the chat. And it was really quite successful. But as mentioned earlier, it meant that it did get to those referrals were coming to a service that actually didn't have, you know, it was maybe not the right time for them. And what we've now put in place is a crisis helpline where that can make a referral straight to that service. So it feels like it's been more successful to change that. That
Thank
makes
you.
sense.
Yeah.
Okay, but yeah, the transitions, yeah. So I think certainly working in CAMS, for the length of time I've worked in CAMS in outpatients and in crisis services as well. It does feel like they're two separate teams, two very separate teams, different training, different, I guess, I suppose, services that they're providing. And we don't always have those links. So I think the thing that we need to be doing better is having more understanding of each other's service, having better relationships, making better links, working more jointly. And we've talked a lot previously about, you know, transition services and working from 0 to 25, which is the ideal. I suppose that's something to keep looking at. But where we're at the moment is we've got a lot of services that still only just go up to 16. Some that will go up to 18. It's so disjointed that then when it comes to that transition time, you know, we're working up. When we're working in Greater Manchester, like the crisis service that I work in, it's so hard to know actually who and when and you know, to contact. So there's a lot of work to be done around trying to standardise this transition period as well. That there is some areas of good practice. I think certainly the all-age mental health liaison teams that now work in the A&E service, part of our crisis team. We've done a lot of joint working with them and a lot of training from our service to theirs around what is different about those younger people and what helps them, listening to those that have gone through the transition. And making those timely referrals, so thinking sort of way before, sort of 6 months before contacting that service, and you know, working with them. The other bit for me is around the use of GPs more. So often when a GP's made that referral to a CAMS service and it comes towards the end of their treatment, if they are becoming 16 and they feel like there is still a need, maybe at that point, instead of jumping to the adult mental health services, it could be back to the GP. I think we're trying to look at that a little bit more now. A lot of GPs provide really effective service and very sort of needs-led. At that time, the criteria for adult mental health services are, you know, the young person might not fit that criteria and then they fall through the gaps. So from a children's mental health point of view, it's about bridging that gap, but it's about building sort of more connections. I think that the other example I would have given is like the joint response vehicle as well, which although is an adult service model, and they're looking at, and we've done a couple of pilot studies on that, about how that could be more effective for under 16s. And it's looking at more practical things like that, where we are working together.
Thank you. That's great, Sally. Thank you. Bekah, I'd like to bring you in on this now as well and get your perspective, please.
Yeah, great. Thanks, Andre. Absolutely agree with everything Sally has said there. I think just one thing to add to that is to make sure that whilst we're improving the communications between services, the voice of the user is the thing that is core to that and is central to those shared goals that we might be making. And it's about amplifying the voice of children and young people and then supporting it where we can. And obviously to do that, you first need to make sure that you do understand the needs of your children and young people. So ensuring that you're truly co-produced in the work that you're doing, and then supporting that when you're sharing this good practice with how you've done it and then the outcomes as well, so that everyone can see that you're not just making requests of them. It's this is what we've done and it's improved our services in this way and support children in this way to add the depth to that relationship building.
Brilliant. Thank you. Yeah, really important. Paul, can you add to that as well now from your perspective? We haven't heard from you yet. Come in and talk a bit about continuity.
Yeah, I mean, I could speak as a academic, as a practitioner, or as a carer myself. But I'll start off with my sort of health services researcher hat on. And so if you look at, there isn't actually a lot of good evidence around transition, but probably the best study that was done last 15 years was the TRACT study that was led by Molly Paul and Swaran Singh. I think it was published in 2010, and there was also a review they published in 2015. Actually, the results there were pretty appalling, in that they followed up, I think, 154 young people who transitioned to adult services. I think 5% said it was a positive experience, and they, I think, were almost exclusively in early intervention psychosis services. And for those that don't know them, EIP services were set up for young people affected by psychosis. They spanned 14 to 35 in England. I was involved in setting them up back in the day. And because there was no gap, they were the only ones that reported a positive experience. So I do agree completely with what Sahil was saying about, yeah, it's about communication, stuff like that. But fundamentally, the structure of our services do not support effective transitions. I mean, I can say, speaking as a practitioner now, you can get people 6 months in advance trying to get around the table. A lot of what they come back with is they don't fit our criteria. There's nowhere for them to go. And particularly if you're talking about people affected by developmental issues, if they're neurodivergent, you know, where do people with autism go? Where do people with ADHD go? Even something as simple as an 18-year-old who needs someone to take over prescribing of their stimulant, it's very, very difficult for people. They really struggle. It's not as bad as when I started out, in that now there are people who say, you know, offer some sort of adult ADHD, autism services, but the waiting lists are absolutely phenomenal. And even then, it's often just assessment rather than treatment follow-up. So I think we fundamentally need to think about the way we structure our services, particularly as our neurobiological research shows that the brain is adolescent until you're about 24, 25. Some might argue if you're a male, maybe up to 45, I don't know. But, you know, we really need to structure our services around the science rather than what's convenient around law, and, you know, saying that, you know, if you're 18, you're an adult, therefore you're off to whatever adult services can or can't offer. So I think we fundamentally need to think about the way we're structuring our services. Thank
you. Right, let's talk about choice and bespoke care now. I knew this was going to be a hard one to chair. We're going to run out of time if we're not careful, but we're going to talk now. Bekah, I'm going to come back to you first of all with this one. So let's think about how services can personalise care when we're living in this world where choices are so constrained. You know, some services are more expensive than others. You know, some have more evidence than others. Some just aren't available at all. Yeah. What do you think we can do to help with all of that?
A very difficult but pertinent question. Again, to just bring a co-production perspective to this, I think we want to make sure we're taking a step back and thinking, are we trying to fit personalisation into existing service models, or are our service models designed with personalisation and the voice of service users at their core? Are service design planning meetings, have they got the voice there? And it's not just about looking at feedback, it's having engagement from children and young people from the very start. And if that means restructuring, then that's what it means. I think that question about research evidence is a difficult one, but again, excuse me, we need to be looking at, does limited research in some areas necessarily mean that that area of service doesn't have evidence, or is it that the research funding is being challenged in certain areas? And again, to bring the voice of children and young people into decisions about where funding is being directed, so that we can be sure that our research accurately represents the range of personalisation that we will be asked for.
Thank you, that's great. And how about you, Sally, bringing your kind of practitioner perspective to this? Tell us about choice.
Yeah, I agree with what Rebecca was saying as well about also about, you know, making sure that the more, what we know is the more personalised you know, the care is, the more effective it is. And you know, models around having more time to spend on assessments, listening, getting in-depth information around what that young person needs, the individual needs the person, and then tailoring it to them. Something around, also around sort of scaffolding those existing support networks and relationships and the care that they're maybe already getting. Sometimes I think we jump to say, you need this, you need that, refer on. Often it is sort of gathering that information and thinking, okay, yeah, what's gone well in the past, what's helping, and I think also, you know, we when we're developing our services, instead of thinking about those kind of that brief, you know, seeing somebody so quickly, it is about giving them more time. And also, you know, using the appropriate services, like again, like GP schools. It might be the young person's much more, you know, it's a lot of young people really feel quite scared about going to CAMS services. It can be overwhelming, and the message that we're giving isn't always the right message, that they need that service. It could be something that's dealt with more in schools, school counsellors, things like the mental health in schools teams. Yeah, I suppose it's listening, you know, listening to people, hearing what they're saying, and sort of valuing what they're saying. And again, you know, the voice of the child, we bandy it around a lot, but actually in getting a true choice and bespoke package, then, you know, we need to be listening and hearing what they say and putting that into place.
Thank you. And finally, and this is a real challenge to talk about this in 5 minutes, we're talking about organisational culture of learning. This is the big kind of area where the project's had lots of really interesting recommendations. And I guess we're interested in your thoughts on how services can ensure that staff have opportunities for this kind of reflection and supervision, and to be innovative in a service that is so stretched and where resources are so scarce. Paul, do you want to talk about this first?
Yeah, happy to. I mean, from a sort of workforce perspective, we know people's relationship with their line manager and their quality of supervision really determines work satisfaction, probably more than almost everything else. I think people's definition of supervision seems to vary across professional disciplines. So sometimes it can be, and I've seen this in, you know, some not necessarily health sectors, like it might be just going through tick boxes. Have you filled out the correct paperwork for your patients? Have you done this and that? It's not necessarily a space for people to, you know, it's not necessarily a therapeutic space for people to feel contained and to, you know, think about how they're working with, often doing a lot of what we might call intense emotional labor. And unless you have that, people are either going to burn out, go off sick, or, as we see, sometimes unfortunately become fairly callous or cynical in their work. And, you know, some of the young people I've talked to about their experience of creation, they will tell me pretty unpleasant stories about some of the encounters they've had with clinicians. So I think for me, it's really about having people effectively job time, to allow that time and making it part of people's everyday work to have that supervisory space, that kind of say, therapeutic for them, not just about ticking boxes, I would say.
Thank you. Absolutely. Sahil, do you want to come in and add to what Paul said there?
Yeah, I suppose reflecting from the review of children and young people's inpatient services that we did at NHS England, one of the things we found was just building in the time in small blocks. So starting with that 5 minute kind of, 10 minutes, kind of increasing that. I think right now services are really stretched, and we do see our frontline staff working incredibly hard at providing care, but unfortunately you can't provide that care if you don't have that space to reflect. And some of this is also having senior leadership and executive leadership support based on wards who can support their staff to actually have a space and hold a space. So I think we need to reflect that not just within our frontline services, but also, for those who kind of commission and also oversee services, senior managers need to be seen on wards actually, talking to staff, talking to patients, and making that time for people.
Fabulous. Shermin, I'm going to come to you with the last word on this, on organisational culture. What do you want to add?
Oh, no pressure for the last word, André. I think both Paul and sort of Sahil have sort of honestly laid out the basics there, and there's not much to add to it. I think probably the only point to add here is services tend to be different, challenges are different. So I think innovation around making this effective and making this what really means something to people is something about asking them how is it best to do. That again requires time, that again requires support from the leadership, but really asking the staff team how best we can do it is probably the best time to start. Simple thing like supervision may not be just having half an hour with your line manager. It could be talking to somewhere broader in the team around a particular issue. It could be another clinician, a kind of senior clinician, or anybody else that you need to. So I think we do need to, in my view anyway, broaden out the definition of supervision and ask people as well as to how best we can do it. And it might be different from one service to another, but that's absolutely fine. The rest of the points that people have made just have to be the basics, without which I don't think we can do it.
Fabulous. Okay, I'm going to draw it to a close now and say a big thank you to all of the panelists and all of the speakers, the presenters who've worked with us today. And a big thanks also to all of our participants who've joined us and given up an hour this Wednesday lunchtime. We're going to be in contact with you in the next few days, sharing lots more videos and links. You're going to be overwhelmed with evidence, but I hope you find that all useful. Please do share that with your colleagues on your social media, with your networks. This is ongoing research. And yeah, I think it's been a really constructive and positive discussion here in Children's Mental Health Week. So I hope you've all enjoyed it. Thank you for your time, and we'll see you again soon.